Good evening, everyone. I'm Aaron Broadwell, president of CSRO, and welcome back to another one of our Business of Rheumatology series that's become quite fun and popular over the last couple of years. I do want to thank Johnson and Johnson. They have sponsored this year's quarterly Business of Rheumatology sessions, although I think there's been some asking to try and do more because there are so many things going on these days. But thank you, J&J, and hopefully y'all are going to learn a lot tonight. We've gathered a great group of people. Please, so we are recording this, so don't ask if we're recording. It's there. Everybody who actually registered will then get a link to the recording. Please, if you have any questions, put them in the Q&A. So the Q&A, not the chat. It'll help us organize everything. We may answer kind of like as we're going, or we may kind of leave them till the end, depending on how the flow of everything's going. But tonight we're going to be talking about the big beautiful bill, or OB3 or O3B. I couldn't remember what Melissa or somebody said. I messed up your acronym already. And it's a very amazing time. We kind of set this a while ago, and now is implementation and what all's happening. So I don't think it could be any better time. And I'll go ahead and open it up to Dr. Dave, one of our board members, who's going to be moderating this session, going through practical strategies for practices and what all is going to be going on with HR1 or the big beautiful bill. So thank you all for joining us, and thank all the panelists so much for giving your expertise.
Thanks so much, Dr. Broadwell. So yeah, my name is Amish Dave. I'm a rheumatologist practicing in Seattle and on Bainbridge Island in beautiful Washington State. And I'm really delighted to welcome some panelists with us. We have Melissa Horn, Lennie McDaniel, and Adrienne Hollander. And maybe I'll let them introduce themselves in that order. So Melissa, if you don't mind going first.
Sure. So my name is Melissa Horn. I am the State Legislative Affairs Director, aka the state lobbyist for the Arthritis Foundation. I've been with the foundation for the last over 3.5 years, I guess, already, but I have been a state lobbyist for multiple health organizations on and off for the last 20 years. Originally from Missouri, but I live in the DC area in Maryland. And my educational background is from the University of Missouri, both with a bachelor's in political science as well as a master's in public policy and administration. So I have, worked on health policy for the Arthritis Foundation, mostly with a focus on accessibility and affordability whenever it comes to making sure that people are eligible to get covered, which is what we're talking about today, as well as can afford the treatments that they're set out to adhere to. So the goal is to make sure that those living with arthritis can lead the life that they want to. That looks different for a little bit of everybody, but mostly it's living with chronic disease. And I'll just put a note as a personal note here. I'm a three-time cancer survivor, so I often work with our partners at the American Cancer Society as well as other chronic disease groups in partnership working on a lot of these issues. So, as a patient and as someone who works frequently with doctors, I'm just honored to be able to work with the rheumatologists in this arena, as well as the patients that bring their stories, which are so impactful to the change that we're seeking. So that's a little bit about me.
Thanks, Melissa. Lennie?
Yeah. Hi, I'm Lennie McDaniel. I have been with the ACR for 10 years now. I'm the Senior Director of Advocacy and Government Affairs at this point and the head of our DC office. When I started with the ACR, we did not have a DC office, and all of our lobbyists were contract lobbyists. And now we have a team of 7 up there. So we're really proud of what we've built. And before that, I was a Health LA with Ways and Means and some other healthcare policy positions. I have my JD from the University of Georgia, go Dogs, and my political science degree from Birmingham Southern College. But I'm just have really loved this work for the last 10 years working with rheumatologists. I think they're a very specific specialty that are really in it for their relationships with patients and for patient access to care. And it's work I feel really good about every day. So it's an honor to be here in furtherance of our policy goals and what we try to do to make sure that we can do everything we can to support our members serving their patients. It's a great mission to have. So I appreciate you guys having me.
Glad to have you here. And then last, I see Dr. Adrienne Hollander.
Thanks, Amish. Hi, I'm Adrienne Hollander. I'm a rheumatologist in New Jersey, South Jersey by Philadelphia. And actually, today I just realized this is my 22nd year anniversary at this practice. So I've been here for 22 years. When I started here, I was the youngest. Now I'm the oldest. And we've expanded from one location to seven, and now we're 18 providers. I'm also on the board of CSRO, and I find patient access and physicians' practices near and dear to my heart, trying to make both of us healthier.
It's really nice to have all three of you here. So we're going to delve down into it, into talking about what I'll call OB3, not to be messing up Star Wars, but I really like that acronym. And Lisa's going to help me with the slides here. So OB3, or the Big Beautiful Bill, contains a lot of different things. So this is Public Law 119-21, and it was signed by President Trump on July 4th, 2025. And so there's a lot of different components. There's tax code changes. So it's meant to increase, or to, I'm sorry, to extend, to make permanent the 2017 Tax Cuts and Jobs Act. There are temporary deductions for tips and overtime pay. Ultimately, the bill does not eliminate taxes on tips, overtime, or Social Security. These changes are transient and will occur for 2 years and then expire. There's new private school choice tax credits, and it also raises the standard deductions that families can take and individuals can take on their taxes. Next slide, please. In addition to all the tax code changes, there's reductions in SNAP, the Supplemental Nutrition Assistance Program, with billions cut from that program, as well as Medicaid restrictions and changes to renewable energy. So there's stricter able-bodied work requirements for Medicaid. Most adults up to age 64 will have to fill out a lot of paperwork showing that they're working, volunteering, or participating in a work training program for at least 80 hours a month. And this includes veterans, unhoused persons, and former foster youth who will be subject to these policies now. And in addition, there's going to be increases in immigration filing fees at every point in the immigration process. The bill or the law eliminates incentives for renewable energy. So that $7,500 tax credit for electric vehicles actually expired at the end of 2025 and was not renewed in this bill. In addition, though, there's increases in defense funding, so over $150 billion extra for the Department of Defense, and increased funding for border security and immigration enforcement. The law actually also increases the statutory debt ceiling to accommodate all of these changes above. And the next slide. So that kind of gets me to Melissa, who has a lot more information about how OB3 affects healthcare. Melissa, I mean, there was a great article in the NBC News just today about some of these changes, and I was reading numbers like a $911 billion might be cut in healthcare funding. That we're also going to see a lot of changes to, not necessarily because of this bill, but this bill does not include extensions of subsidies for the Affordable Care Act. And so I've saw some numbers suggesting that 10 million individuals in the US might lose healthcare coverage by 2034. And we're already seeing the SNAP changes occurring. And so I saw numbers of 450,000 people just in Arizona alone have already lost access to SNAP and food benefits. There's also, I guess, in February of this year, a report from a study done by the New York Federal Reserve that suggested that 10% of households are saying that they're food insecure and not able to afford food for their families. So we're already seeing a lot of changes in OB3. What can we expect in terms of healthcare? It seems like Medicaid is going to see a lot of changes in particular.
Absolutely. And I would say, when I think about the terminology used for the framing of this legislation as it was going through the congressional process, it certainly is big, but I would argue that it's not very beautiful. It is very difficult as you're looking through these healthcare components, especially. But I would say, in terms of, what's framed as safety net programs in general, there's certainly an attack on that. And whenever you are looking at our most vulnerable patient communities, those that are low income or disabled, living with chronic diseases, this is really going to be a critical time for us as advocacy organizations representing patient groups, as well as physician groups, to speak up about these changes. So you mentioned SNAP. I actually have seen that so far 3.5 million people have lost benefits, and that's that Supplemental Nutrition Assistance Program. they've kind of framed the Medicaid changes around mirroring those eligibility standards. But it's important to note that there are a lot of new requirements in place for eligibility for Medicaid, specifically. So I did want to overview that and really talk about how critical it is to have Medicaid access. It is the nation's, if you want to go to the next slide, it is the nation's largest health plan. So it is the largest source of health coverage in the United States. It covers 74 million people. That's 1 out of every 5 Americans is on Medicaid. Whether they realize that or not, because a lot of states do call it different things. I think the phrase, as I work with state legislatures as well as Medicaid directors, is if you've seen one Medicaid program, you've seen one Medicaid program. So in terms of how they're run and how they're funded, all of these variables can differ state by state. So it's really critical that we protect access to this, especially as folks are going into another open enrollment season this fall, but also as folks are renewing their coverage. So some of the changes that we're concerned about will affect these populations. So Medicaid is really geared towards, free or low cost coverage for low income adults, children, pregnant women, elderly, and people with disabilities. As you mentioned, there's changes from the One Big Beautiful Bill, OBA or OB3 or HR1. There's a lot of terminology there, that will affect eligibility and how it's determined. So the biggest one that we're concerned about for the Arthritis Foundation, where we've spent the majority of our time, is around those work requirements. So you had noted, for new enrollees and for continuing renewals, those aged 19 to 64 must document a minimum number of hours, and that's 80 hours per month, either working, volunteering, or in school to keep their coverage and to qualify for coverage or get an exemption. Now, the exemptions, again, can vary state by state. And I will say that CMS, or the Centers for Medicare and Medicaid Services, has not been very definitive in providing guidance for the states on this. So there's been a lot of back and forth, and I'll cover that in the slides ahead, over how to implement this because it is federal law. It was signed by President Trump. So states have to recognize that it is the law of the land, and they have until 2027 to start to adopt this or codify or put it into place in state law. I'll cover in a little bit, but there is some legal challenges to it that now exist as of this week. But the main concern is how are states going to pay for these changes, if they want to continue to cover people who might lose coverage, especially if they lose Medicaid coverage, they could get pushed to the marketplace plans. And without those subsidies, those enhanced premium tax credits, a lot of marketplace plans have increased their premium cost and are high deductible plans, which we all know as patients living with chronic diseases, having a high deductible plan can be like living in copay quicksand. It's impossible to really budget for your healthcare whenever you're managing a disease that can be very expensive. So right now it's projected, and we look at a lot of different resources for this, that up to 10 million people could lose their Medicaid coverage under these new requirements. Of course, for our focus, those living with arthritis or other rheumatic diseases, we're really concerned about what kind of documentation they might have to provide, along with the burden that will be placed on rheumatologists and other physicians in providing documentation for them, whether that's getting them to qualify for an exemption or if they do self-attest at first for a new diagnosis or when they first enroll, which CMS has said they can only do during 2027, and in 2028, they want the documentation. What is that going to look like? And is that a cost? What is that actual cost for both physicians and that community, but also businesses and charitable organizations that will have to provide proof of those 80 hours? So there's a lot of questions at play here, but this is just the overview of like the big thing that's happening. There is also changes to rural health funding that's in a part of this big, beautiful bill. And there is changes in terms of how states can manage coverage for immigrant populations. So the federal standard is not to cover immigrant populations, but in some states that have expanded, they have covered women and children, like California and some other states. So that kind of challenges those notes in terms of who can get covered. The expansion states, those that expanded their Medicaid enrollment eligibilities, are definitely struggling in how to adjust and adapt to these standards. So that's the overview. If you want to go to the next slide, I can keep going, but feel free to, ask any questions along the way because this is a lot of information. I apologize to all the text slide. Usually I'm more of I just talk and share than have you all having things to read, but there's a lot of information to digest here. So I know we'll share the slides, so don't feel like you need to memorize all of this. But this slide goes through who must report and what income eligibility levels exist. But it's important to note too who is exempt, because those are the definitions that we're really paying close attention to, especially those with special needs or are considered medically frail. We want to make sure, again, that patients have every opportunity, whether they're still waiting to be diagnosed and experiencing symptoms that are debilitating, or if they've already been diagnosed, to make sure that they don't lose their coverage if they're having, flare or a bad month that they can't meet those 80 hours. So it's really important to note kind of like the circumstances of who's applying for Medicaid. But like I said at the beginning, 74 million Americans, that is a large part of the population, and it's 1 in every 5 Americans. So whether they know it or not, this age range of Americans really need to pay attention to the changes that are happening.
And Melissa, just looking at these numbers for the eligibility income, it seems like, if you're working at all, you would likely make at least 15,000 in a year, even if you're a part-time worker. So we're really talking about anyone who's working at all on Medicaid's now being required to report and unless they're medically exempt, versus if you're on total disability and not working at all, you might not be subject to these requirements. Is that a correct way of looking at things?
Yes, it is. And I would say again, too, it's important to note that just because this federal law passed doesn't mean that states can't go stronger than that. And we have seen states do this already, with North Carolina being an example. Right now, the federal law from OB3 or OBA says that there needs to be one check every 6 months. But a lot of states are looking at making it even stricter. So think about that as you are a patient from that lens, or as a physician having to take on that additional documentation and proving your status to get those exemptions. And, honestly, the trauma of having to re-dictate that you have a chronic disease every time just to stay insured. The problem with us in having work requirements as the standard for coverage is it really puts this marker on patients to prove ability. And as the leading cause of disability in every state and nationwide, it's really hard for us to think about that standard for insurance to be put in place like this. It almost reminds you of the pre-existing conditions that existed before the Affordable Care Act and the push to high risk pools of getting people off of healthcare coverage that is more affordable, like Medicaid is, and onto high deductible, high premium plans that they can't afford to pay for. So all of this is really critical to pay attention to, and certainly has become one of our 3 top issues at the Arthritis Foundation to work on.
And
So
I think another question we had was just about medical frailty and what that means.
absolutely. So if you go to the next slide, this is actually, you guys are right on for the flow of this. Medical frailty, in terms of how CMS, Centers for Medicare and Medicaid Services, defines it, is really broad. And having a qualifying condition isn't necessarily enough. Even if you have a diagnosis code for a disease like arthritis, you still need to prove that because of that diagnosis code that you cannot participate in the 80 hours per month. So there's no actual list of conditions that the federal government is prescribing states to provide, though some states are working on lists. So we are, doing outreach to Medicaid directors as well as executive branch offices and legislative leaders to see how they're defining it. Because again, every state can be very different in how they define medical frailty. But as you can see here, there's a lot still up to those states. They can develop lists of qualifying health conditions, but they can't exempt because the federal law restricts it based off of those code lists. So, for example, states can't just call out and say everyone living with arthritis, cancer, AIDS, Parkinson's, multiple sclerosis, like any of those diseases, they can't just call out and say, well, you're exempt from that. They still have to have the standard of having an assessment for the individual. And again, individuals can only self-attest during 2027, starting in 2028. They can do it once at enrollment or when they're newly diagnosed. But after that, for the eternity of their healthcare coverage applications, they need to provide proof. So what does that proof look like? Well, it's an excellent question. CMS has not provided the details for that. And it is something that states are really struggling to define. And if you continue on, I can go through the state's landscape here. So again, 2027 is the big year. Some states have already started to work on this. So far, if you look at it, Arkansas and Georgia already have work requirements in place for their Medicaid eligibility. They've had laws for a couple of years now. But Nebraska is the first state that has early adopted the federal standard, and that started in May. So we haven't really seen kind of the consequences of this yet, though I will say that the Arthritis Foundation will be releasing our assessment of how Arkansas and Georgia's laws have affected those living with arthritis in terms of their ability to enroll and maintain coverage in the coming weeks. So just keep that nugget in mind. We're trying to study this and understand the impact on the patient community. But Nebraska, again, is really trying to implement this federal standard and figure out, are they going to have a list of codes? They've already requested comments from patient groups and other stakeholders to really see how to implement this better. But so far, like, people aren't kicked off yet. So it's more of a notification process that has gone out in those states. But Idaho, Indiana, New Hampshire have all looked at, along with North Carolina, going stronger than the federal law. North Carolina was actually the worst case scenario. They had additional lookbacks where you had to prove for 3 months prior to enrolling that you've met this 80-hour work requirement. So if you're a new applicant to Medicaid, starting your application and realizing that you have to go for the last 3 months and go get documentation of those 80 hours, or you're not even going to be able to apply, is a real hard element to meet. And certainly one that the Arthritis Foundation, ACR, CSRO, we actually did a media release to, say our unhappiness with this decision. But that was a very fast vote and part of their Medicaid funding bill. So legislators that were opposed to that element didn't really have an opportunity to stop that legislation from going into effect. But, we're really looking at this landscape across the board. And I would say for us, we're trying to go state by state and talk to the Medicaid directors, talk to the attorney generals, talk to the executive branch offices about what adoption looks like. Are they going to have a code list? Are they going to do more lookbacks? How are they monitoring compliance? Because again, every state Medicaid program is also their infrastructure and how they check things is not built for this. So the states are going to have to put an influx of cash into the infrastructure to actually monitor and track enrollment in a new way. So that's not an easy task because a lot of states are not doing well with their budgets. And how do you fund something new? Are you going to tax folks? Because Congress didn't provide money to implement this either. So talk about an unfunded mandate. This is probably the biggest one that we've seen in healthcare in some time. So if you look at the slide again, we can share it. It just kind of gives the lay of the land of number of states that are considering this and the feedback. And this is from Kaiser Family Foundation. What states are currently reporting on how they're going to tackle this. So I highly recommend checking out their data. They've been doing a really good job of, asking questions to state leaders to see how this is going to be implemented. So we'll go to the next slide.
Yeah, and Melissa, I'm gonna ask you and Adrienne in a second, but I feel like that slide just gives me so many questions because I'm wondering now, if I have a patient with rheumatoid arthritis and they're doing well on their adalimumab or their abatacept, are they no longer frail? Will they be frail if they're not on their medicine?
Right.
I guess, but they have a condition that predisposes them to potential frailty. And what does frailty mean? And this is going to be a state by state issue. And what if my patient wants to move from Washington State to Texas? And, is this going to limit people's options to move from state to state, especially if they move to a state that's more restrictive? And then how often are we going to need to assess, quote, frailty? Is it a simple document online? How much
Yeah.
staff time do I need? And then is a physical exam necessary or can televisits suffice? And what's the difference between frailty and disability? And it seems like it's kind of variable, and frailty could lead to disability if you don't have insurance. So, anyways, I have a lot of questions, and it's nice to know that I'm not the only one.
No, you are definitely not alone. And every single question that you just asked is what states are asking also. Because again, CMS has not provided guidance on this or set even a form or a guideline for how to do this. So this actually flows right into this next slide because there is, as of this week, a multi-state lawsuit that was dropped. And this complaint actually was filed with 23 state attorneys general, two governors, and DC against the federal government over work requirements because of the language and the lack of guidance in the rules that have come out so far. So again, I can certainly send out a link if you want to look at the states that are involved in that. But even again, the state of North Carolina, it's interesting to watch their governor kind of go against their legislature. But what does he have to lose at this point? It's a really big debate because as patients go on this, I would assume that the first patient is even going to have a legal challenge because, if you are doing your best to provide documentation and there's no standard of what is required and you're still kicked off and lose coverage, you're jeopardizing someone's life, and progression of disease. We all know for arthritis, especially, first of all, it takes a long time to get diagnosed, but it takes sometimes even a longer time to become stable on a treatment that works. So, all the things that you were talking about in transient patient populations going from one state to another and having all these variables of what to provide to make sure that you're exempt from this, even temporarily, if you have a temporary hardship until you become stable again, are all valid questions and certainly ones that have legal implications. So, if you look at the complaint of this, I am certainly no lawyer, but I would highly encourage you to follow it because this lawsuit is massive. It is certainly something to pay attention to. I can't say for certain that I'm confident that it will stop the implementation efforts that are already underway, especially with Nebraska and some states already early adopting. However, it will certainly slow the discussion down and provide groups like ours with an opportunity to be able to explain the real life patient experience and how this could affect both patients and doctors in navigating coverage and continuing treatment in a way that patients are able to work. Because I think the messaging here is there's this belief that people on Medicaid don't want to work, and that's not true. Like you had mentioned before, if you're making within those thresholds, usually you are working a job. It's not like people, especially in this economy, can survive without doing something. It's just
Yeah, exactly.
the ability to do something and do it consistently every month for 80 hours. That's quite a bar to put into place. So again, this is a big week for this particular issue, and I highly encourage you to follow along. Washington State is the state that announced the multi-state lawsuit, but there are many states that are a part of it. I would say, I think every expansion state that expanded their Medicaid eligibility is a part of it. But it is quite a mix. It's not just, a red or blue issue. I always say our issues usually aren't. It doesn't matter your political persuasion. This healthcare and health access is not a political issue. It is part of living as a human. You need to have access to care. So, big announcement for this one. Definitely pay attention to that lawsuit. If you want to go to the next slide here, I promise I won't take this whole webinar up, but we are working with many, many other organizations on this issue. I think there's over 80 that are a part of our National Coalition of Patients Protecting Care and the Modern Medicaid Alliance, where we have put together kind of our key priorities about protecting that medical frailty language and exemption and make it broad enough so it can capture both those that are diagnosed with diseases like arthritis, but also those that have yet to be diagnosed that wouldn't be able to meet this standard. We don't want to see coverage loss. And I would argue that pretty much every Medicaid director is about that. And even stakeholders that we usually oppose on legislative issues like insurance providers, we're all at the same side of the table on this one. We don't want people to go without healthcare coverage. So we're trying to engage early and often, state by state, and just really work with the decision makers on every category around it. And we're focusing on the fall open enrollment and early adoption states to make sure that they're capturing, again, that real life patient experience. So we will have more resources. Again, we're studying the 2 states that have laws already on work requirements. But as states adopt, we're going to be watching those numbers on how it's affecting claims data and patient eligibility and enrollment numbers. So I think it's the last slide if you want to go to the next. Follow us. We are on social media. We are trying to collect people's experiences, especially if you are working with patients that are on Medicaid or that probably will apply for Medicaid or have loved ones on Medicaid. We want to hear how the experiences are right now and kind of watch the difference as this happens. But we also will have action alerts and opportunities to engage as we work state by state all the way through. One easy way that you can stay in the loop with the Arthritis Foundation is to text arthritis to 50457. That gets you in for our action alerts. But you can also go the email route. You just go to arthritis.org/advocate and you can follow any of the action alerts state by state that we initiate. So
Thanks,
that's
Melissa.
me. And I'll put my contact info on the last slide there.
Great. Well, Adrienne, so I mean, there's a lot of information that Melissa just went through about OB3, and I'm just curious, like about like how you're looking at it. I feel like we hear from a lot of rheumatologists in CSRO that they might be private practice, they're not necessarily employed or necessarily working in academic centers, and so we hear that they might have only a small number of Medicaid patients. But I also feel like we're part of a larger community, and that we might be consulting the hospital or patients by Medicaid or undocumented. How do you look at this when you think about like all of the rheumatologists that you're working with? I think you said like 18 rheumatologists in your practice or across many different clinics. What does that mean for you in New Jersey?
Yeah, thanks, Amish. So I think, what kind of in looking into this, what this brings me back to is 20 years ago when I first started. I had a patient who was an endocrinologist, and at the time he was 80 years old, and this was 20 years ago. And he basically told me a story that he remembers when Medicare went into effect, when the safety net was kind of put into effect for Medicare. And he said this really stopped patients from dying. It was so impactful to get Medicare. And to kind of be here in this time when we kind of feel the safety net is being ripped out under us, is really impactful. So I kind of feel as doctors, physicians, rheumatologists, we really have an obligation to do everything we can to help our patients. Um, and you're right, in private practice, sometimes people don't take Medicaid, but it impacts us. I think when we go to hospitals, we're going to see patients who are underinsured or uninsured completely, and it's going to put more work on the physician as far as helping patients get access to care. I think we're going to all have to put processes in place in our practices on how to document medical frailty, what that's going to look like. That's going to put more resources and more burden on us as physicians and our practices to have our staff help us with that. And I think that all of this with OB3 really comes on top of the ACA issue, which is that they let the enhanced premium tax credits expire for Obamacare and the ACA, which makes that the premiums, as you said, go up by like 58 or 60%. So even if someone's not on Medicaid or they drop off Medicaid, they probably won't be able to afford to get into the ACA premiums. And we know just that tax credit loss, like you said, will have about 10 to 12 million people lose their insurance. And so this impacts all of us because we're going to really see this divide in medical care. And what we do, we'll have more people kind of going uninsured to hospitals, hospitals taking more of the burden, us providing more free care somehow. And even in private practice, if you don't take Medicaid, you might see your volume decrease or shift at least because people can't even get onto the ACA marketplace anymore. So I think this is very impactful for all of us. We all need to advocate for it. But I know that I want to hear also what Lennie has to say, and I don't want to take up all of your time.
Yeah, Lenny, I think I know that we have been hearing at CSRO from a lot of rheumatologists across the country about stress that they've been having about people losing access to subsidies and now the impending cuts that are coming, almost $1 trillion from healthcare and the social safety net with OB3. And it seems like this is a time when people need to get engaged more than ever with groups like CSRO and ACR. Tell me about what's been going on at ACR and how you guys are lobbying and advocating and engaging our rheumatology colleagues.
Sure. And we'll do just a very broad overview. We're very lucky to advocate on alongside both CSRO and the Arthritis Foundation so often on these important issues. We can go to the next slide. One of the things we've struggled with, and even when I was working on the Hill, there was a real thought that maybe it wasn't physicians' role to educate policymakers and to lobby and to advocate. So one of the things that I think has shifted now that unfortunately policy is impacting physicians so directly, they're ready to get involved and ready to advocate. But one of the reasons why that is the role of physicians and organizations like CSRO and ACR is that members of Congress literally only know what they knew when they came into office. There's this idea, especially, when I was on the Hill, that you just automatically have been bequeathed with all of the information in the world about every bill that comes through the office. But you really only know what stakeholders come in and tell you and what constituents come in and tell you. Otherwise, you're going to either rely entirely on your party caucus position, or, what a special interest that has the bandwidth to come tell you their position comes and tells you. So if rheumatologists are not in the office, then there's no way for an office to know how a policy will impact us or what any negative impacts could be for our specialty and our patients. And there is almost always that voice on the other side coming into the office. So it's really important for us to also be around. And this is just a reminder that while there are 20 physicians in Congress, there are no rheumatologists. So there's no one on the Hill currently thinking for this specific specialty. So that makes it even more important that we advocate on its behalf. Next slide. So our approach is really three-pronged. We have a political action committee, which supports re-election campaigns and candidates for office who are pro-rheumatology, who we have the opportunity to discuss policy measures with and their policy positions with. Policy education, which our lobbying staff does alongside a lot of coalition work that we do, which often includes CSRO and Arthritis Foundation, because we have so many shared issues. This includes policy letters and formal comments and statements. If you go to rheumatology.org/letters to policymakers, we've probably sent more letters in 2026 and 2025 combined, but than any previous administration. And then our grassroots and community connections. And so that's our members. The membership is really, really crucial as it reminds lawmakers that this impact that we're talking about, Melissa and I might be talking about on a global stage, is actually happening in their districts, in their states. The patient population are the voters in their districts, are the people that live, are their neighbors, are their friends, do work at the grocery stores around the corner, so that grassroots connection with our membership is really vital. So I know that that's a really important key aspect for all of our organizations. Next slide. This is just a reminder that even though tonight we're talking about a piece of legislation, it's really important to be advocating not just to members of Congress, where our lead is a lobbyist named Paige Colston, but to also lobby to regulatory agencies and state lawmakers. I know a lot of you know Joseph Cantrell and the great work he does. We also have Shweta Haldar on our team who lobbies to our regulatory agencies, which has really, Congress and the regulatory agencies have really melded over the last couple of years. And I'm about to get into that a little bit with one of the issues in HB1 or OB3. And then we also lobby directly for private payers. So where you guys are seeing downcoding or denial of claims, we have a lobbyist on our team that directly interfaces with private payers to smooth over any rheumatology specific issues. So for any of the advocacy team members listed, you can find us at advocacy@rheumatology.org for practice issues and downcoding and things like that in your area. I know that we are seeing some issues with Orencia in the Carolinas and the Southeast. That's practice@rheumatology.org. But please make use of those resources. That is why the team exists. So that operates out of the DC office. And then we also design and execute our policy priorities, obviously, and then disseminate our RheumPAC funds, which has slightly shifted this year to a lot more aggressive support of candidates over just sitting members of Congress. So we're really participating in some races this year where it's not just a current member of Congress, but some challengers. And we're really excited to be able to have more of an impact as it looks like 2028. Well, it looks like the next Congress is going to be not look a lot like this Congress, as we keep seeing a lot of the incumbents are losing their races. We've had a lot of retirements. So that's really a key part of our advocacy and making sure that we have the funds to get to know those new members of Congress. Next slide. So this is just a list of how we advocate through Hill Days. I know you guys have one coming up on October 2nd. We just had ours on June 2nd. So it's really good that we are hitting the Hill with our rheumatology priorities, both in spring and in fall. So I think that makes a lot of sense. Obviously, mobilizing through our Legislative Action Center, which I have a QR code coming up. We do have a current issue in our Legislative Action Center on Medicaid that allows you to directly lobby Congress on this issue. Building relationships with Congress, grassroots, and RheumPAC, as we've gone over. Next slide. And RheumPAC, is just a reminder, is the only federal PAC that is pro-rheumatology and that focuses only on rheumatology issues. So if you want to join us or join RheumPAC, that QR code will take you to RheumPAC, the RheumPAC webpage, which gives you more information. It's a great educational tool. It's a great way to get involved and get the resources that we need to either get to know the new Congress or keep the people that we are working positively with currently, and that are still working hard on behalf of patients. Next slide. Okay, so I wanted to offer a little bit of context outside of just OB3 as to what the administration and Congress has been doing. So this is a funding bill that passed in March, which was obviously after OB3. But 2025 was a really, really tough year for healthcare policy and advocacy. And then we had this bill in March that gave us a lot of things we've been asking for a long while. It reinstated both the arthritis and the lupus line items in the Department of Defense research programs. It increased funding for NIH after the president's administration asked for like a $16 billion cut to NIH funding, and rebuked the proposed caps on facilities and administration fees on research grants. So Congress really kind of stepped up, especially in the research area. It also extended the telehealth flexibilities, where previously those flexibilities had been attached to the funding bills. So every single time there was the threat of a government shutdown, all of a sudden there was the threat also that Medicare would not be reimbursing telehealth visits. So I know, especially when we had the shutdown this year, there was some real concern with our members as to whether they should even be seeing people via telehealth. A lot of telehealth appointments were completely canceled because we had no assurances they would be reimbursed. And then CMS, after we reopened, says, well, of course, we're going to reimburse you backdated for those appointments. But of course, there was no indications as to that. So we were thrilled to see this 2-year extension that takes us out of that kind of rat race and takes that flexibility out from being attached to those funding mechanisms that are less predictable. And then it started down the path of reforming PBM business practices, which is, of course, has been a big issue for all the groups on the call tonight, and really inflates and decreases access to treatments by inflating the price of drugs. So we were excited to see those steps. Next slide. What's currently happening, just for context for any questions that might come up, we are working on the Medicare reimbursement reform package that is coming out of the combined efforts of the Republican and Democratic doctors' caucuses. So that has some interesting stuff in it, but we're thrilled to be collaborating with them on possible Medicare reimbursement reform. Obviously, I think the number one issue for our physicians are the thin margins and reimbursements that are keeping are limiting patient access to care in our workforce especially. So we've been constantly beating the drum on this issue. Prior authorization legislation just got through the E&C Health Subcommittee. And then we have a Senate Finance RFI that's reaching out for more policies to lower drug prices, where we will be hammering home the underwater biosimilars issue and access to Part B drugs, especially considering that the Inflation Reduction Act Medicare price negotiations include Part B infusion drugs for the first time on their list for 2028. Next slide. And these are just some administration advocacy things. We have an interoperability standards statement going for prior authorization. Obviously, as Melissa touched on, we will be commenting on the Medicaid work requirements and the definition of medical frailty. That comment letter is due at the end of July. So we've been working in collaboration with the Arthritis Foundation on that a lot. OMB put out a really disturbing rule about research at the end of May. So we will certainly be responding to that. And then I will get into some student loan changes that came out of OB3 that we've been interacting with the Department of Education on. Next slide. Okay, so back to Medicaid. As Melissa went over very thoroughly, which makes this a much faster process, there are a lot of cuts to Medicaid. We are certainly concerned, Medicaid accounts for $1 of every $5 in the healthcare system currently. We are certainly concerned about what that means for our rural providers, for rural hospitals, for our pediatric providers. Those are the people that we're hearing from. We still don't know what the restricted Medicaid resources are going to mean for dual eligible patients that are primarily Medicare patients but rely on Medicaid to fill in the gaps. We don't know if those resources will even still be available. So we are certainly commenting on this and advocating for this. One of the things that we're doing is advocating to Congress to be incredibly lenient with the application of good faith waivers for states. CMS distributes those waivers, but we're hoping that members of Congress, as the representatives of their states and as the people who included a waiver option in OB3, to be lenient with states for all the reasons Melissa mentioned, that implementing all of these new guidelines requires a completely different structure, new employees, et cetera. And so we think that a lot of states might be pursuing the good faith waivers that are included in the bill. Obviously, defining medical frailty, as she so thoroughly went over, and communicating the impact of work requirements, documentations on physicians specifically. I think that they can say all they want that this needs to be renewed every 6 months, but I don't think that they've really come to understand as policymakers what that means in a healthcare context, and what getting an appointment every 6 months means, what not including a billing code for this specifically means for physicians, whether they will even see a patient for this or whether they will just bill for a physical, or what we're going to have to do to actually make this work. But we're getting a lot more guidance if this is the way that they want to operate. So we are certainly communicating all of that to the administration. Next slide. One other thing that is in OB3 that we haven't touched on, but today is very timely because it all gets implemented today, July 1st, is the changes to professional students designation and all of the changes to professional student loans and just student loans. So one of the big changes was the change to the definition of professional students and the caps on loans. So I won't read all of this, but essentially only 11 degrees now count as a professional degree. That includes an MD, it includes a JD, it includes a list of 11 degrees. If you're pursuing those degrees, you are capped at $200,000 of loans over the lifetime of your education. And if you're pursuing any other degree, you are capped at $100,000. We think this is catastrophic for the workforce. This makes becoming a doctor, you either have to be born rich or you have to rely on private loans. So we've been communicating with the Department of Education throughout this process to communicate our disturbance and how we think this is going to impact the workforce, and to at the very least hopefully get an exception for medical degrees. But we'll see what happens. Next
Yeah,
slide.
Lennie, I
Yeah.
find that slide so interesting because just today in Washington State, I was working with a University of Washington medical student who it costs him $90,000 a year to go through medical school. So the $200,000 cap makes no sense to me whatsoever.
No. And the theory behind this is that it will force institutions to reduce the cost of education and the cost of tuition. But I have not heard from any educational institution that their plan is to lower costs. So it'll be interesting to see how they justify it if that is not the reaction of these institutions. Um, Next slide. Awesome. So this QR code will take you to a special edition of the Room Advocate, which is our bi-monthly newsletter that includes all of the information I've just said, but just every other week we do an update on everything that the team's working on. But we did a special edition with all the changes being implemented for student loans for July 1st. One of the things that is pertinent to this is even if you're not a new student or not a new loan taker, every single person with a current federal loan will have to readjust their payback methods because the federal government has now changed it to there's only two pathways to repay your loan, and you're going to have to pick one of those two pathways moving forward if you still have a federal student loan. So it is pertinent even to those who are not students. And then our last slide here is just a QR code for our Legislative Action Center, where, like I said earlier, you can take action on the Medicaid issue or any other issue that I've discussed. One thing I did want to add just before we move on is one of the things that also happened in the Big Beautiful Bill, which actually was kind of beautiful, is there was a 2.5% plus up for the conversion factor for the Medicare physician fee schedule. So our physicians did see a 1 year increase in reimbursements via Medicare from January 1st, 2026 to it'll expire December 31st, 2026. So while we are incredibly appreciative of that, we have also seen no movement to extend that. So we think that there will be a bit of a cliff at the end of the year on top of everything else we've discussed. So wanted to make sure we included that.
Well, so much to unpack in only like 5 minutes at the very end. I know that there's a lot going on, and we welcome people's questions in the Q&A box. But I think um, uh, I'm seeing some comments that are already coming up, and I want to take some of those. But Adrienne, when I'm thinking about like everything that's been discussed today, I see it as so much more important than ever that rheumatologists and really any healthcare provider, clinician get involved, either in strengthening or getting involved in their state rheumatology association, getting involved in national level organizations. I think that ability to just say like, oh, I'm just going to do my job, but not participates at all when such major changes are occurring, and whether you have to pay student loans, whether your kid can go into a nursing degree or into a medical degree or become a pharmacist in the future, on whether, what's going to happen to your patients on Medicaid. I just see it as more important than ever to get involved. I'm curious about like, what you're getting out of this.
I completely agree. And I think that people don't quite realize how impactful physicians can be when they go and they talk to either their state or federal representatives. If you're in a state that has a strong rheumatology society, I'd encourage you to get involved. And if it doesn't, I would really encourage you to get involved in the medical state society, because I think that it's more important than ever to really be involved. And I know that, Aaron, I wasn't sure if you wanted to touch base about CSRO, what CSRO is doing to help the state societies.
Yeah, so clearly, so we are supporting all different types of societies. We're looking in societies where there's not a lot of advocacy at making new societies. We're doing all kinds of things. We have grants that you can apply to CSRO to help fund getting the legal paperwork, et cetera, for a society moving. And so lots and lots of things that are available there. So if you don't feel like you have good local advocacy, send us a message, info@csro.info. We'll help everything start getting going. Because if we don't have the boots on the ground in the different states, we run into problems. One of the largest states, two of the largest states in the United States don't have effective advocacy arms as far as rheumatology goes. And those places typically suffer and they don't have as good of laws and everything else. So, and then from a CSRO perspective, also, because it was mentioned earlier, if there's anybody in the CGS area with Orencia that's being worked on, there's some major issues from the Medicare perspective there. Just make sure that you had the ACR link earlier. You can go to the CSRO website, the Payer Issue Response Team that I'm the chair of. We'll shoot you an email back usually in 48, 72 hours, something like that, if you have any things that aren't working out. So like I see something in the chat about it's in the chat, not the Q&A, about not seeing Medicare bumps or something. You send something through there. I mean, you should automatically be getting those. It should be something baked in, and you should be seeing your E&Ms bumping to 0.5%. And if you're not seeing that, there's some inherent problem that's going on. So please let us know. They did put it in a link in the chat. If you have insurance related issues, that's the CSRO method. But Amish.
Yeah, and I just want to just add to that, which is, some of the questions that come up. Even if you don't yet have a rheumatology state society, reach out to us. We're really eager to kind of help set up state societies. And in recent years, we've been working with Montana, with Utah, with Illinois, with other states that might have a large number of rheumatologists or a small number of rheumatologists, but want to gather together. I was just meeting 2 weeks ago with Oregon rheumatologists to try to revive the Oregon Rheumatology Alliance and emphasizing that these changes that we're seeing in insurance and Medicaid, Medicare, private insurances affect everybody, and we all have to kind of work together, whether we're in academics or in private practices or employed. And also, definitely really important to get involved in your state society, because even if your rheumatologist society is very small, like in the case of Montana, the state medical society likely has a lot more push. And I'm always amazed at how much I can do as one board member of our Washington State Medical Association as a rheumatologist and talking about prioritization and red tape and insurance hurdles. I wish everyone the same luck. And so I think getting involved in your state medical society is huge. And then also put a pitch in, obviously, for our AMA and Arthritis Foundation colleagues. I've conflict of interest served as a board member of Arthritis Foundation Great West, and we've had wonderful folks with Heidi Barrett being involved in Olympia and work in Juneau and in Oregon as well. And then CSRO also has a whole bunch of upcoming events, which I'll let Aaron pitch us for. Here we
Yeah,
go.
absolutely. So, thank all of y'all for doing this. This was something that I had zero expertise in and totally took a backseat to everyone. So we do have our next business rheumatology coming up in September on the 16th. It's going to be around clinical research and some of the, how do people in private practices do this? Clearly, this is different from big institutions. We do have our day on the Hill, as mentioned earlier, October the 2nd. Advocacy conference is right after that. So come for both. We're going to take about 50 something people up on the Hill. We'll get you an extra extra day of hotel, etc. And then contracting and transparency of coverage is going to be in December. A lot of folks are saying, hey, look, we've got to start having better negotiating skills. And then for any fellows or new people to practice, we have our fellows conference. It's going to be in San Antonio, March 19th and 20th. Amish, did you want to have any last thoughts from everybody or?
Yeah, I would just say that I find being involved in advocacy. I was just doing a talk on this at Seattle Children's Hospital for the Pediatric Rheumatology Fellows. I just find it so invigorating. And I just think like we all have an issue that's going to drive us. It doesn't have to be the same issue, but the reality is that if we don't speak up, then we're just grumbling in the background and bothering our partners or bothering our family members and other people around us. Whether it's advocating for your practice, whether it's advocating for your patients, CSRO is really here for you. There are so many different ways to get involved, whether it's about insurance, whether it's about um, reimbursement, whether it's about another issue that's killing you, like practice consolidation of practices. So please get involved. Please reach out to us at info@csro.info. We're happy to hear from you and want to hear your voice.
Thank you all so much for joining. Thank you so much to the panelists for joining us. I hope everybody has a wonderful night.